Yeah, welcome everybody. It's really a pleasure to have you all again on this 102nd edition of the Cameroon Town Hall for healthcare professional. We are starting off this 102nd session with a very important topic, which is an important public health concern that doesn't get a lot of attention in our context in Cameroon. So I'm really thrilled that we have someone to discuss about the scale of this problem, this public health challenge in Cameroon, and also explore some targeted solutions towards alleviating the immense burden of liver cancer in Cameroon. So it's a really great pleasure to have you all join us. Want to start off by welcoming and greeting my fellow co-moderators here, Dr. Elvis, Elvis and Dr. Manuel. Elvis, hi, welcome to the town hall.
Thank you very much, Brian, and thank you to all participants of the town hall. It's a pleasure to be with you again today. As you mentioned, we are having a very important speaker today who is a subject matter expert and really a trusted authority in this field. It's a very important topic, Brian, as you mentioned, not just in Cameroon, but globally. As we are preparing for the session, I was just trying to look at some of the statistics, and I was really astonished to see that in 2020, there were about 900,000 new cases of hepatitis B, of liver cancer globally, with about 830,000 deaths globally. That's really high. And considering that the three important risk factors like hepatitis B, hepatitis C, and alcohol are all the things that are a big problem in Cameroon. You can imagine how this is also a very important problem in Cameroon. But also, I always ask the question, why sub-Saharan Africa? Because in most of this infectious disease, you will hear that the incidence in sub-Saharan Africa is really high. And it is also because of the prevalence of hepatitis B and C that is also very high in this sub-region of our continent. So Cameroon being part of it is not left out. And so hopefully we shall hear from our experts just how the burden is and what the situation is. And actually, when we're discussing at the level of the moderation, the first topic was a cry for help before we actually modified the topic to be the way it is. But that was just motivated by the fact that there is really need for something to be done. So really excited to be here today and to listen to this presentation. Over to you, Brian.
Brian, you're muted.
Yeah, thanks. Thanks a lot, Elvis, for that. I totally agree with you. It's such a liver cancer is such a multidisciplinary condition. Just a multiplicity of risk factors, public health risk factors that we have to address. You mentioned the eradication campaign for hepatitis C that actually started in Africa and still ongoing. I think if we have the kinds of surveillance mechanisms that really helps us to detect these cases quite early and place people on treatment very early, maybe we could alleviate some of this burden. So I think it's one of those that we could, as a public health, if we tighten our public health surveillance effort in sub-Saharan Africa, we can pretty much very well alleviate the burden of hepatitis C. So I'm really looking forward to Dr. Marcel and Nzoume's presentation, and I really hope that through his talk, we will have some targeted and solutions that we could deploy in our context in Cameroon to lift some of these burdens. So really looking forward to an exciting discussion later today. And welcome, Mona, and please, your opening remarks, please.
Oh, thank you, Brian. And today I'm very excited because the presenter today is a friend and also a classmate. And he's a wonderful person. He's one of the most bilingual persons we'll have in this forum. So I would have the privilege to kind of introduce Dr. Marcel Nzoume, who is my classmate back in CUS, and we go a very long way, and we've known each other for more than 20 years. So he's a graduate of the Faculty of Medicine and Biomedical Sciences, and he did his specialization in the gastroenterology and hepatology back in CUS. which is a 4-year course, and later on spent time in France and did subspecialize in hepatology and also in endoscopic procedures. And he's been really dedicating his time to help back home to try to bring advanced GI procedures back home and do them locally. And he's been a champion of multiple things, a champion of trying to get EGD and colonoscopy accessible and available back home. He's been a champion of trying to get early stages of hepatocellular carcinoma diagnosed. So he works in the West region right now, and he's someone who is very modest and doesn't want me to say a lot about him, but you get to know Dr. Nzoume Marcel. He has traveled around the world and he attends a lot of conferences, so he's up to date with what goes on back home. So it's a privilege having a young person. That's what we want. We want people who are going to be young and take over from the next generation and also improve the country. So Brian, I do present you Dr. Nzoume Marcel. But coming back to hepatocellular cancer, I do treat hepatocellular cancer, and it's one of those cancers that has made a big shift. If there is something in medicine that needs a multidisciplinary team, there is nothing like hepatocellular carcinoma, if you're talking about multidisciplinary team in medicine. So in the diagnosis and also in the treatment of hepatocellular carcinoma, you do need a certain level of technical training that the country needs to have. We need to have good interventional radiologists. We need to have a good radiation oncology team. We need a good hepatology team. We need a good hepatobiliary surgery team. We need a good transplant team. And the icing on the cake is that you need a good medical oncology team right now. So in order to be able to treat those things, you need all of that plateau technique in order to be able to treat this cancer. You need collaboration, you need tumor boards. Now, prevention is always better than cure. Cameroon has one of the highest rates of hepatitis B, which is the biggest risk factor of hepatocellular carcinoma. Hepatitis C is also available, found in Cameroon, not tested routinely. We have one of the highest rates of alcoholism and cirrhosis. We do also have things like, we're getting to the point where we're getting obese, also non-alcoholic fatty liver disease. We have alpha toxins, especially in peanuts in the Western regions, which are not well stored. Those are all risk factors. And there are some genetic factors, smoking and all of that, that is found in Cameroon. So it's a pleasure to really have us discuss this topic. And no one other than Nzoume, that's how I call him, Marcel, is going to do this topic for us. And so over to you, moderator. Yeah. And once you have time, you can start the session.
Yeah, thanks a lot, Mona. Before we get started, if you permit me, Mona, I just want to take just a minute to briefly share about the survey. We had a session last 2 weeks where we discussed about the just permit me. I don't know if you're seeing my screen here.
Yeah, it was okay. We were seeing the first intro page of the survey. That's okay. Yeah, that was good.
All right, thank you. Yeah, we listened to the feedback, and with the help of some people in the town hall, notably Jude and Zelefak and Khan, were able to design a survey that will essentially really capture the history of the town hall, what has where we've come from. I think today is the 102nd session of the town hall. Very impactful, powerful discussions we've been having here. So we designed a survey which we are hoping to release or launch out today, and really would employ your help in filling out the survey. The survey shouldn't take more than 5 minutes. Essentially, really, we want to capture some demographic information on some of the people, the participants for this town hall, what your profession is, how long you've been in your area of expertise, and really want to map out where this expertise is, and then and see get some basic demographic information in terms of where people are working and what people are doing. No personal identifiable information, but we really want to use the opportunity to get as much information we can for regarding where people all over those who attend the town hall here, where they likely are practicing. So we'd love to gather some information on that. We would love to gather some information on just the situational assessment of the town hall. What has worked for the last 101 session? What hasn't worked? What are some areas that you think might be helpful for improvement? If you don't think any improvements are necessary, we certainly would love to hear about those as well. Just basically gathering some basic demographic information that would just help us to have a sense of a situational assessment of the town hall, essentially. Then the third section of the town hall is really just a needs assessment, what you perceive as the driving health challenges in Cameroon, and what you think what we think should be a priority, what should we be prioritizing. We're going to discuss today about liver cancer, which is a major cancer in Cameroon, but also we really want to capture people's thoughts on what they consider to be the main driving healthcare challenges, for instance, in Cameroon, and also more importantly, what you would like to see this committee that the Ministry of Health has created to engage the diaspora, healthcare professional in the diaspora, to improve healthcare in Cameroon. So we would love to gather some of your thoughts on this, and as much information you can give us would be super helpful, as well as we launch this survey at the end of the discussions today. So I just wanted to drop that in. We're using a platform called Form R, which was created by a fellow Cameroonian. I just want to acknowledge the person who designed or created Form R. He's called Cyril Tata in Germany. I really just want to extend my gratitude for his support in helping us set up the survey in a way that would be feasible logistically for the launches. So thanks a lot. So we really want to capture some of those healthcare challenges, and also potentially we've discussed about creating policy briefings after these discussions, as we have very important discussions on different health topics, something that could be summarized in concise documents that we could always send to the Ministry of Health, so they have a sense of what the discussions in the town hall have been on. So with that said, I just want to welcome Dr. Marcel Nzoume. Merci beaucoup pour avoir accepté notre invitation pour présenter aujourd'hui, et over to you.
Merci, Brian, de m'avoir passé la parole. J'aimerais tout d'abord saisir l'opportunité pour dire merci à Dr. Mono Kenefoma et toute son équipe, Brian, Elvis, pour ce privilège que vous m'avez donné, donc, d'adresser le Cameroon Town Hall sur un sujet d'actualité et sur un problème de santé publique majeur, qui est donc le cancer du foie, qui fait des ravages dans notre contexte. Mais l'opportunité m'est également donnée de pouvoir féliciter mon cher ami qui a fait des éloges à mon endroit tout à l'heure, et j'ai été très flatté, Dr. Mona Kenefoma, et pour cette initiative de Cameroon Town Hall, et pour votre contribution et tous vos efforts que vous avez consentis jusqu'ici en ce qui concerne donc les sujets de santé qui préoccupent donc la population camerounaise. Et je voudrais à cet effet aussi vous encourager, voilà, de poursuivre dans cette noble mission Et nous espérons que, effectivement, que dans un avenir, que beaucoup de choses vont sortir de là. Donc, une fois de plus, merci. Thank you very much once again. And I will do my presentation both French and in English. So, because I'm French speaking, so, but actually with the culture, with Anglophone culture. So today we're going to talk about liver cancer in Cameroon. So I'm going to share with you guys, but in the public health perspective, because actually Dr. Mono said everything concerning already the subject. So I will just do some kind of, give some kind of facts concerning the situation in Cameroon.
You might be having a challenge, Dr. Marcel. You are mute if you are speaking.
You're muted. Just unmute yourself.
Yeah, good. Thank you very much. So we're going to, my presentation, okay, we're going to discuss about the following points: the overview of liver cancer in Cameroon, the risk factors of liver cancer, the challenges in diagnosing liver cancer in Cameroon, and public health interventions for liver cancer in Cameroon, and also access to treatment for liver cancer. And then we're going to talk about the future prospects for addressing liver cancer in Cameroon. So we all know that liver cancer is a significant health concern in Africa, and particularly in regions where chronic hepatitis B and C infection are endemic. The high prevalence of these infections, along with other risk factors like Dr. Mono just said, aflatoxin exposure from contaminated food as well as fatty liver disease, contributes to the burden of liver cancer in Africa. And limited access to healthcare services and late diagnosis also pose challenges in managing the disease effectively. And lastly, efforts to improve prevention, early detection, and treatment access are very important in combating liver cancer in Africa. So we're going to talk about primary liver cancer because we have secondary lesions, but that will not be the topic tonight. So, and we know that the most common primary liver cancer is hepatocellular carcinoma, which usually develops in people with underlying disease, liver disease, such as liver cirrhosis caused by hepatitis B or C infection, excessive alcohol consumption, or non-alcoholic fatty liver disease. And early detection, as we just said, and treatment are crucial for improving outcomes. So the overview of liver cancer worldwide, we know in terms of incidence, both sex, that is the CIF cancer, behind cancer of the lung, breast, colorectal cancer, prostate, stomach, gastric cancer. So it comes at the 6th position in terms of incidence. In terms of mortality, is a third cause, most common cause of death, cancer-related death in the whole world. So these are some statistics that we got from the these are some recent statistics that we got for the year 2022. So it's the third cause of death worldwide, cancer-related death worldwide. So in Africa, in both sex, is a 4th in terms of incidence, and in terms of mortality is the third cause of cancer-related death in Africa. And in Cameroon, we can see here in Cameroon from these figures that is at the 6th position in terms of incidence, behind cancer of the breast, the cervical cancer, prostate cancer, non-Hodgkin lymphoma, and Kaposi and sarcoma. And in terms of mortality, is the 4th cause of death in Cameroon. So what are the risk factors for liver cancer? It has been stated already, but we would emphasize the case of Cameroon, we know that chronic infection with hepatitis B and C these are the major risk factors for liver cancer in our context. Liver cirrhosis also, certain inherited liver disease, diabetes, non-alcoholic fatty liver disease, exposure to aflatoxin, and excessive alcohol consumption. So here we have all the factors that actually will act on the liver, and that will lead to liver carcinogenesis or liver cancer or liver-related death. So Africa's silence epidemic, we all know that now hepatitis kills worldwide more than HIV, tuberculosis, or malaria. So tackling the hepatitis B virus, for instance, in Africa is one of the key to fighting back liver cancer. Worldwide hepatitis B is a worldwide problem, and we have about 270 to 290 million people who are chronically infected. And 1/3 of the world population have evidence of exposure with more than 800,000 deaths per year. And we can see that Cameroon here, was in sub-Saharan Africa, is in the hyper-endemic zone with a prevalence rate that is more than 8%. So in Cameroon, the general prevalence from this study that was published, the general prevalence is 11.2% for hepatitis B, and the HBe antigen prevalence is 91.1% in those patients who are HBV, who have the surface antigen positive. And the most prevalent genotypes are A and B. So we also have cases of co-infection with the Delta virus. And we know that the co-infection with the Delta virus changes the natural history of viral hepatitis infection. And therefore, people who are co-infected will more develop complications such as liver cirrhosis. We also have hepatitis C with a prevalence of about around 4%. But we should note that, okay, we have a decrease in the incidence of hepatitis C in Cameroon because when we get back to the medical history in Cameroon, we understand that most people were more infected by this virus where people were born between the years 20s and the year 60s. And studies were done and which suggested that, okay, in the past, there was an iatrogenic transmission of hepatitis C. So we believe that, okay, in future, with this decrease in the incidence of hepatitis C virus in viral infection, that will have less complication due to hepatitis C viral infection. So we have also cases in terms of the prevalence of the co-infection. HIV, hepatitis B is 14% in Cameroon, is 14%, and the co-infection hepatitis B, hepatitis C is 0.6%. So in Cameroon for hepatitis B, the prevalence in male 8.5%, female 11.6%. In rural area, the prevalence is a little bit high, 13.3%. In urban areas, we have a prevalence rate of 9.9%. And within blood donors, which is very important because there are still areas in Cameroon where blood is being donated without cross-checking or without being sure that, okay, there is no, doing a second or a third generation test to be sure that, okay, that blood is free from hepatitis B or C virus. So, and that prevalence is about 10.5% that we should take into consideration. And in pregnant women, we have the prevalence of 9.8%, but there are some studies where we have that prevalence of 13%, which has to be taken into consideration. So what are the ages of patients that we see for hepatitis B in our therapeutic committees? Most of them are within the range 20 and 29, so less than 40 years. So 65% of them. And that's why we understand that, okay, hepatitis, the liver cancer is mostly found in that range of population that we have in our country. So after all this, we suggest what is being suggested is that the contamination in Cameroon is from an early age, and 80 to 90% of infants infected during your first life and will develop obviously a chronic infection. 30 to 50% of children infected before the age of 6 will develop also chronic infection. So we all know the outcomes of hepatitis B virus infection. We know that infants they are at high risk. In 80 to 90% infants infected during the first year will develop chronic hepatitis B, and obviously will develop complications that we all know, liver cirrhosis, and then liver cancer. So, and for children, your risk is intermediate. 30 to 50% of infected children less than 6 years old will develop chronic HBV infection. And for adults, the risk is low. Less than 5% of healthy HBV-infected adults will develop chronic HBV infection. And the disease progression is related to the HBe antigen, is also related to the viral load. But what we note in Cameroon that, okay, we will see people with a very low viral load developing liver cancer or hepatocellular carcinoma. So the host genetics also accounts, and the viral genetics also, and there are other factors such as concomitant alcohol consumption. So the other issue here is that we should know the prevalence of HBs antigen in pregnant women in Africa. We can see here our country, Cameroon, we have a prevalence of HBV antigen, the surface antigen of 13.4%. And it's very important because we know that, okay, the main route of transmission in our context is mother-to-child transmission or perinatal transmission. So if we want to tackle this issue, we should take into consideration and lay emphasis on mother-to-child prevention. So what is the percentage of pregnant women attending at least one antenatal care visit? So it's 82%, not bad, but we obviously see that, okay, the percentage of birth attended by trained medical personnel in our context here in Cameroon, we can see here is 63%, which means about 40% of them, those pregnant women, they give birth out of the control of the medical personnel, and thus will not be able to effectively do any all the protocols concerning the prevention. So in our context here, the transmission of hepatitis B virus is largely in early childhood. It is mainly a perinatal transmission. And most of the time, the status of the mother during pregnancy is unknown, and some of them give birth at home. We have also in the unsecure medical procedures such as, and also as well as traditional practice that will actually also favor the transmission of the virus. This was a study that was done and published in 2017, showing the prevalence, the frequency or the prevalence of hepatitis B in the 10 region of Cameroon. So we can have an idea here with the North region with the prevalence of 20%. Yeah. So and there's a kind of disparity because there in the North we have 20% and in the South we have 18% prevalence of hepatitis B. So other studies were also done concerning risk factors of hepatocellular carcinoma in Cameroonian patients. We all see that, okay, the first year is hepatitis B in 48% cases. 48% cases in 48% cases, the risk factor that was identified for hepatocellular carcinoma was HBV infection. So we have other factors, but the most prevalent factor is HBV infection. So the prevalence of hepatocellular carcinoma according to age, gender, and liver cirrhosis. What is noted here is that most of our patients, I'm sorry, I wanted to highlight, but the 25.4%. We can see here that most people who have in our context hepatocellular carcinoma, according to the age, is the range between 30 and 39. So under 40 with 25% here, which is very, very, very high. So, and we understand, we also have here that, okay, liver cirrhosis people without liver cirrhosis also in 40% cases can also develop hepatocellular carcinoma. So without passing through the stage of, without having any underlying liver disease. So what is the prevalence? A study also was carried out showing the prevalence of hepatitis B associated hepatocellular carcinoma in Cameroon with respect to age, gender, and cirrhosis and liver cirrhosis. And here again, we have that high prevalence within this same range, 30 to 39. So yes, 47%. And men are more concerned than women. And in almost 60% cases, it appears on a cirrhotic liver. So here again, the prognostic, a study was carried out and was published recently in February 2024, talking about the prognostic factors of hepatocellular carcinoma in Cameroon, a cross-sectional study, and that gave a characteristics of the study of hepatocellular carcinoma of patients with hepatocellular carcinoma. So we can actually see here that the first cause, again, the first risk factor remains hepatitis B. And what we can also note is that, okay, most patients that are being diagnosed of liver cancer or hepatocellular carcinoma, they are being diagnosed in a very late or advanced stage, because actually we have more who are being concerned by the classification, by the Barcelona classification. Mostly is the stage C that we see most of the patients that come for consultation. So at the Bafoussam Reference Hospital, we have a committee where we usually, a multidisciplinary committee where we usually talk about we usually discuss cases of cancer. And we have realized that, okay, from during the year 2023, the first cancer, digestive cancer in terms of frequency was hepatocellular carcinoma, followed by colorectal cancer. So after hepatitis B and C infection, I just want to say a word concerning non-alcoholic fatty liver disease, which is the leading cause of chronic liver disease worldwide, and its prevalence increases with that of metabolic syndrome and its component. We all know in our context, we have more cases of metabolic syndrome. And this non-alcoholic fatty liver disease is associated with complications such as cirrhosis and hepatocellular carcinoma. And in this study that was carried out and that was published recently also in 2023, it shows that, okay, the prevalence of non-alcoholic fatty liver disease was 48.9%. So what are the challenges in diagnosing liver cancer in Cameroon? Now we all know that, okay, the problem is a major problem. It's a public health problem, a major public health problem. What are the challenges that we face daily? So in diagnosing, so it should be noted first of all that the percentage of the population, of the Cameroonian population living on less than $1 per day is 33%. So that's already a limiting factor. So we understand why. So why we are presenting this slide. So we have limited access to diagnostics tools. That's the first thing, because we have lack of advanced imaging facilities, limited availability of ultrasound, for instance. There are in some regions, in some remote areas of the country, we don't have access to ultrasound, CT scan, MRI, which can hinder accurate diagnosis and staging of liver cancer. We have such shortage of skilled specialists, as Dr. Mono just said, hepatologist, oncologist, radiologist. So in the entire Cameroon, we just have 60 hepatologists. I want to acknowledge the presence of my colleague, Dr. Japa, who is online. So this insufficient number of specialists will lead to a delay in the diagnosis or in even for the radiologists in interpreting imaging results, impacting timely diagnosis. And then we have the high cost of diagnostic tests, as we just said, because actually more than 32%, 33% are living on less than $1. So they might not be able to afford some of those tests. So financial constraints often prevents patients from undergoing necessary imaging and laboratory tests for early detection. That should be noted. So we also have limited awareness and screening programs. The low public knowledge about liver cancer, because of lack of awareness, result in delayed presentation of symptoms and missed opportunities for early detection. That's why we can actually see people coming in a very advanced or late stage, where we can really give them a curative options or therapy. So we have inadequate screening initiatives. So the absence of organized screening programs leads to a significant portion of cases being diagnosed at advanced stages. Limited availability of tumor markers also is not everywhere. It's not in all our labs that we can actually do those tumor markers. So when we're out of some regions or head of hill regions, it becomes very, very, very difficult. And then we have treatment limitations and access barriers. So among them, we have inadequate access to specialized care. So geographically, disparities and limited specialized center impede patients' access to appropriate treatment facilities and expertise. And then we have also financial barriers to treatment. The high cost is true that, okay, we just have some few centers where they can actually do liver surgery. The high cost of chemotherapy, immune therapy, the high cost of radiotherapy, and even we can also discuss, we can also even talk about the availability, and then which makes the curative treatment options inaccessible for many patients in Cameroon. So we have the shortage of liver transplant facilities. We don't have none. And I even think even in sub-Saharan Africa, we don't have, I think we don't have. And even if those who even have, so those who have the means to go abroad, at times it might not be very easy for them to benefit from liver transplant. So what are the public health interventions for liver cancer so far? So knowing the epidemiological factors influencing liver cancer, our interventions, the interventions of the Cameroon government, okay, is focused on these factors. And one of them is the prevalence of hepatitis B and C in Cameroon that we know, the high prevalence of both, the association with aflatoxin exposure, and aflatoxin exposure is a significant risk factor for hepatocellular carcinoma in Cameroon due to dietary habit and agricultural practice. And Dr. Mono just said the consumption of peanuts mostly in the West region here. The impact of alcohol consumption. Alcohol consumption plays a role in the development of liver cancer in Cameroon, necessitating public health measures. So we have the tendency to underrate our alcohol consumption here in our country. So the influence of socioeconomic status also, socioeconomic disparities, because we have some countries such as in East Asia where the prevalence of liver cancer was very important, and the amelioration of the socioeconomic conditions helped to decrease in some way the incidence and the outcomes of liver cancer in their country. So we also believe that, okay, these socioeconomic disparities also contribute in the incidence of liver cancer in our country. So what are the preventive strategies and screening programs? So we know that it is noted for the vaccination for hepatitis B that since 2005, within the expanded immunization program, that there was the vaccine against hepatitis B was introduced. But we all know that, okay, there is a problem because those who are born from mothers who are who have the surface antigen positive, from 0 to 6 weeks, okay, there is no coverage and there's no serotherapy to prevent the mother-to-child transmission. So our plea is the implementation of the vaccination of the vaccine against hepatitis B at birth that will actually reduce the incidence of hepatitis B, which is a major risk factor for hepatocellular carcinoma in our context. The promotion of safe food practices. Promoting safe food practices can help mitigate aflatoxin exposure and thereby reducing the risk of hepatocellular carcinoma in our country. Enhancing alcohol awareness and support services. We have to raise awareness about the risk of consumption, of excessive consumption, and providing support services that can help prevent liver cancer. Accessible screening and early detection programs also should be put in place, should be established in order to improve the outcomes of liver cancer in our context. So treatment options and healthcare infrastructures. When we have availability of surgical and radiological interventions. Dr. Mono just said, he talked about the good interventional radiologist. So that's also a problem. That we actually ensure availability, ensuring availability of surgical and radiological interventions is essential for treating some cases of liver cancer in patients in our country. So we in Yaoundé, for instance, we know that, okay, there's a team that is working on that, of a team of interventional radiologists, so which has to be encouraged. So improving access to liver transplant services is, comme on dit en français, it's not something that we have that we're going to have as soon as possible, but we believe that is going to help us in life-saving treatment for advanced liver cancer cases in Cameroon. So strengthening oncology and palliative care, that's very important, because those patients who come in late stage or advanced stage, they should benefit from, they should be managed properly. So they should not be condemned to death without having a proper management to accompany them and relieve them from their sufferings. So strengthening oncology and palliative care in Cameroon services is crucial for improving the quality of life for liver cancer patients in Cameroon. Capacity building for healthcare also is very important. So we have also community engagement and awareness. So educational or risk factors and symptoms. We have to educate the community about risk factors and symptoms of liver cancer and facilitate early detection and also intervention. The engagement of traditional healers and community leaders, because actually I would say in Cameroon here, when we talk about hepatitis, the first thing, okay, that comes is something that cannot be managed by conventional medicine. So most of our patients are being managed, or the initial management is being done by those traditional or doctors or herbalists. So there should be a kind of collaboration with them. So policy development and implementation, advocating for policies focused on liver cancer can lead to improved public health strategies and resources allocation in Cameroon. Support groups for patients and caregivers, also very important. We believe that we have to establish support groups to provide emotional and practical support for liver cancer and your caregivers in Cameroon. So research and also data-driven initiatives, because we have said a lot of things, but we don't have the exact figures with the exact figures of liver cancer in our context, simply because, okay, in terms of data collection, there is a problem on that. So epidemiological research and surveillance, conducting epidemiological research and surveillance is essential for understanding the burden of liver cancer and guiding intervention. Leveraging also should be done for genetic and molecular studies to provide insight into the specific factors contributing to cancer, because actually we see that, okay, in most cases that we have here, the cancer, liver cancer is very, very aggressive. So we believe that there are some other genetic factors beside the hepatitis B infection or hepatitis C infection. There are other genetics factors that comes into action, and that can explain the aggressivity of this of liver cancer in our context. So we also have, it's also important to integrate traditional medicine, as I just said, and we should have to use data-driven approach to actually have a good analysis of the problem. So access to treatment for liver cancer in Cameroon. So what I'm going to say, we have challenges in accessing treatment because we have limited healthcare facilities. So access to specialized cancer treatment centers is restricted due to the capacity, due to the scarcity of healthcare facilities that we have. We have financial barriers, the high cost of treatment and lack of insurance coverage pose significant financial barriers for patients seeking care. And then we have a lack of skilled medical professionals all around the country, with such shortage of hepatologists, shortage of radiologists, shortage of oncologists and specialized healthcare professionals that will obviously hinder the delivery report of quality cancer care. So I know we have some other geographical constraints. Patients in remote areas face challenges in accessing treatment centers due to their position. So quality available treatment options, availability of advanced therapy, for instance, still limited availability of therapy such as targeted therapy and immune therapy that impacts the quality of if treatment options. We have standardization of care, the lack of standardized protocols also, because cancer is being managed in some areas. There are people who are actually in some health facilities. We don't have a multidisciplinary council to be able to discuss the cases of these patients and to provide them the best that we have. So we also have challenges in accessing essential medications for cancer treatment. We have also inadequate and inability of supportive care services in our context. So awareness and education are very important. So lack of comprehensive public awareness campaigns contributes to low understanding of cancer symptoms and treatment options. Limited educational programs for patients and caregivers hinder understanding for the disease and the available support. So insufficient training for healthcare providers also on cancer diagnosis and treatment impacts the overall awareness and education in the healthcare system. So we also have cultural beliefs and surrounding cancer create barriers to awareness and education as far as the disease is concerned. So we have so many options here. So whenever there's a situation, so we talked about the cultural belief. So most people believe that, okay, some is witchcraft, those are things that cannot be managed medically speaking. So what are the future prospects addressing liver cancer in Cameroon? 1, community outreach program. Implementing community outreach program to raise awareness about risk factors, which is very important, symptoms and preventive measures. Mega campaigns, we have to screen, and those who are at risk also, they should be managed early. School-based education, we have to, the incorporation of cancer awareness and prevention in school curriculum to educate the younger generation is very important also. Healthcare provider training healthcare professionals to recognize symptoms and provide counseling is also very important for early detection. Improving healthcare infrastructures, we believe that the government should invest in advanced diagnostic equipment and facilities for early detection in all of our health facilities. And building expanding treatment centers with specialized expertise in liver cancer management is also important. And ensuring access to affordable treatment options and medications for all individuals, including marginalized communities, is also very important. And lastly, the implementation of telemedicine programs to provide remote consultation and follow-up care for patients in remote areas. So lastly, research and innovation. Clinical trials should be carried out. Genomic research, innovative therapies also should be explored, and collaborative research network. But yet, the most important thing remains the prevention of the risk factors. We cannot actually, nous ne pouvons pas nous donner le luxe au Cameroun de parler donc de la prise en charge du cancer du foie, la prise en charge sur le plan thérapeutique ou curatif. Et comme Dr Mono l'a dit tout à l'heure, c'est-à-dire la prévention vaut mieux que la guérison, c'est-à-dire vaut mieux que prevention is better than cure. Donc, nous devons plus axer nos efforts sur la prévention des facteurs de risque. Et moi, je pense que voilà, pour ce faire, que nous allons pouvoir donc faire reculer donc le cancer donc du foie. Sur ce, je vous remercie pour votre aimable attention. Merci.
Oh, merci.
Thank you for your kind attention.
Yeah, merci beaucoup, Marcel. I really admire your bilingualism. So thanks a lot. I just wanted to take a moment to acknowledge the presence of the dean of the Faculty of Health Sciences of University of Boya, who is here with us, Prof. Halikane. So welcome, and It's really great to have you among us. I want to take a brief moment also to transition to Dr. Mono. Dr. Mono, and if there are any questions and comments you would like to contribute to this discussion, we would love for you to raise your hand, and you can also use the chat box to drop your questions there, or some comments that you might have. But Dr. Mono, I would like to hear a little bit more about really engaging presentation from Dr. Marcel. I really want to hear about the standard of practice in the US. If you could maybe take a few minutes to maybe share a little bit about what you see in the US context in terms of what the scale and what the scale of the problem is, how therapeutics is being managed, how diagnostics is being managed. He talked a little bit about the Barcelona liver classification, and I'm wondering if that classification is appropriate in the African context, like in Cameroon. So I'd love to hear a little bit more about what you see and what your experience has been, Dr. Mono.
Thank you, Brian, and thank you, Dr. Marcel and Nzoume, for the wonderful presentation. And as always, you always deliver. And I told you guys, I promise you that this was one of the most bilingual persons I know that I turned to school with. So as Marcel said, prevention would be the best way we can fight hepatocellular carcinoma in Cameroon. There is no other better way than prevention. We're still many years away from properly managing these patients. I would just use 5 minutes, Brian, to tell you what we do. As I said, beginning, the Barcelona criteria is so important in order to decide how you're going to manage hepatocellular carcinoma. Without going into so much details, it's one of the cancers where you get a true participation of what we call interdisciplinary team management. Right now in the US, we're getting retrospectively to educate hepatologists, radiation oncologists, and also to educate transplant surgeons, because a lot is going on in the medical field. This is the first cancer that used to be one of the cancers that was managed by everybody except for the oncologist, but is becoming a big cancer that is in the oncologist realm. So there are things that you would get, there are dogmas in medicine, like in hepatocellular carcinoma, you don't need to biopsy the liver. But now, in my practice, my present practice, I try to get tissue on everyone for multiple reasons. I have several other oncologists here. The reason is because we want to differentiate between hepatocellular carcinoma and mixed hepatocellular carcinoma and cholangiocarcinoma, which is an entity that we find. And we also need to do what we call a next generation sequencing. So why is this cancer particular? Because majority of the case, patients will need an ablation when the lesion is identified early. You can do resections based on that Barcelona criteria that Nzoume told you. I'm not going to go into the details of that. You can also do transarterial chemoembolization. You can do what we call transarterial radioembolization. These are all things you can do. And there is a place now for systemic therapy. Now we're having the ASCO meeting in the US. After ASCO, we would have neoadjuvant therapy, or what we call adjuvant therapy, even after TACE and after embolization. Those are new things that are going to come into play. So here is just a little slide summarizing what Nzoume said. In terms of management, we need multidisciplinary team. How equipped are we in Cameroon? Radiation oncology, we have some radiation oncologists, but there's a lot of shortage. Accessibility is just in Douala. And I think I saw Dr. Anne Myson here. She's a radiation oncology. You can do SBRT to those lesions, but it's not our choice, our first choice. We usually want to make sure that these patients, if they are transplant candidates, we get to transplant them. We also get to involve hepatologists in order to help us with diagnosis, prevention, and treating the other underlying causes such as hepatitis. If they can be resected, you want to do that. And we have hepatobiliary surgeons that are involved in resection and transplant surgeons that are involved in transplanting the surgeon. Interventional radiology is still in an infancy stage in Cameroon. I know there is a group of French interventional radiologists who come to l'Hôpital Général Douala, and they are introducing TACE. There's Y90, which is practiced a lot more in the US than in Europe. which is what you call transarterial embolization. And after this, we're actually giving treatment, systemic treatment. So in terms of advanced liver cancer, this is the ESMO, which is the European classification of what you do. You see that it's based on the Barcelona staging and the classification A, B, C, and D. So we used to, as medical oncologists, another problem we have back home is access to the first-line treatments that these patients need. What is the first-line treatment? They do need immunotherapy called atezolizumab with a VEGF called bevacizumab, which Bev is available in Cameroon from what I know. I've treated a lot of patients back home, but atezo is not, and it's super expensive, and few people know how to give it or are trained to give it. We do have sorafenib, which is available, but that's an old medication and has a lot of toxicity. Lenvatinib is also not available, but this is what you see that in Cameroon, if we are going to treat these patients, we need a lot of work to be done. We need to train the medical oncologists and train the rest of the other subspecialists about the changes. So as I did say, this is really the plan of care. We also have other drugs such as durvalumab with tremelimumab. We have other treatments that have just been approved. They are all immunotherapy, which is not accessible back home. It's super expensive. Most patients are flying to India in order to even get access to TACE, to get access to TRACE, to get access to surgery, to get access to transplant. So a lot needs to be done. And I think Cameroon really needs the diaspora for those who are able to do that. And those in Cameroon need to accept the diaspora that are trained in order to train our surgeons and also to train our doctors back home. There is no better way than collaboration. So here is just the last part of me saying that a lot has changed. Why a biopsy is necessary is to actually be able to identify certain subtypes which are more like cholangio, hepatocellular carcinoma. We do molecular testing in all these patients. We run an NGS in a lot of these patients, and we have targetable mutations. We are not there yet, but I would love to say I want to thank Marcel for a wonderful presentation and for doing a public health approach to this problem and highlighting hepatitis, which we have had access to hepatitis vaccine for a long time in Cameroon. How many of we do prescribe hepatitis vaccine to those who are not privileged to be under the age group that could get hepatitis? A lot of us can buy these vaccines and take them, but how many of us do take them? Because it's the biggest cause of hepatocellular carcinoma. There is access to hepatitis C treatment. How many of us do test our patients and treat them? Alcohol and cirrhosis, there is NASH now. Aflatoxins, how many of us actually do educate agricultural education? There is genetic testing that needs to be done for certain groups of people, hemochromatosis. There is diabetes and smoking. There is environmental factors and occupational factors. So this is really a truly interdisciplinary team in order to treat, but I think prevention, it holds the highest standard in Cameroon. So Brian, this was the little 5-minute thing I wanted to say, and I just want to thank Marcel for accepting our invitation and putting on a show as usual, and maybe we go over to question and answer sessions.
Yeah, thanks a lot, Mono. Thanks for sharing this view on how this is managed in the United States. It's really great to see and appreciate the difference between both. In 2016, the World Health Assembly held a meeting where I think they launched the eradication campaign for viral hepatitis for 2030. And really highlighting what the scale of this problem is in Africa and why we should strategize and redesign surveillance systems and infrastructure to eradicate viral hepatitis in Africa. I want to give a chance, Elvis. I just want to, while we give our speakers some time to maybe take a brief, cup of water or a brief breath. What were your thoughts on the presentation, and how do you perceive this problem?
No, I think it was a great presentation, Brian, and I want to thank Dr. Marcel once again. And like Mono mentioned, it was a public health approach, which was really unique. And I'm always keen to pick on some of those very basic things that we find ourselves not able to do, but that can really lead to a tremendous improvement into just limiting the prevalence of liver cancer. It was astonishing to know that we still have 40% of pregnant women give birth without the help of a healthcare professional. This compounds a problem of early transmission, as he had mentioned, and these are really things. So as you see, healthcare is integrated. As we are talking about liver cancer, we are still talking about maternal and child mortality. We're still talking about blood transfusion issues. It was really also astonishing when he mentioned the the prevalence of hepatitis B virus that is related to blood transfusion alone. That's from blood donors. That's really, really a serious issue. And we all have very easy resources like rapid diagnostic tests that can be used at the point of a blood transfusion. And we still cannot understand that some blood transfusion can go on without screening for very important infections like hepatitis B virus. So I think it's really been a great presentation. I did a little summary, and I hope I'll be able to share that with those who are not able to follow up the presentation from the beginning, but open up for questions. And I'm really glad to hear the thoughts and perspective of the other town hall members.
Yeah, thanks. Thanks. I was also astonished to hear about the scale of the hepatitis B and C burden in Cameroon. So I think we'll transition over to questions. I see Joel and Donjo, if you can just briefly introduce yourself and then share your question. Joel.
Joel, if you're speaking, you are muted, so maybe you might want...
Hi, can you hear me?
Yes.
Hi, great. Thank you very much for the presentation. I joined a little late, but I was still able to pick a few very interesting aspects of this particular cancer care in Cameroon. So my name is Joël Dunfio, and I lead our hepatitis C virus project at Treatment Action Group, which is a civil society organization and a health and policy think tank based in New York. So just a couple of points and 2 questions. So I'm curious as to which DA or direct acting antivirals. So my intervention will mainly be in terms of prevention because I work on HCV, right? Which is treating HCV prevent this particular HCC, right? So I'm curious as to which direct acting antivirals. So these are HCV treatments we have in Cameroon. Now, the reason I want to know which we're using and also the price is because I presented at a conference that happened about 1 year ago. I presented virtually. The conference took place in Geneva. And this was a viral hepatitis resource mobilization conference put together by CHI, that's the Clinton Health Access Initiative, the Hepatitis Fund, plus a number of other partners. And the goal was to engage with global funders and other donors on the possibility to mobilize these global donors behind viral hepatitis elimination that Brian mentioned. So the goal of the WHO, of course, is to eliminate viral hepatitis by 2030. Now, during that conference, while it seems like they weren't able to raise the funding they had aimed for from the get-go, they were able to get Viatris and Hetero, and these are WHO pre-qualified manufacturers of HCV treatments, right? These are the main ones, Viatris and Hetero. They were able to get them to commit to reducing the price of these DAAs to $60 for the full treatment course of HCV in all LMICs. That is why I want to know which DAAs we're using in Cameroon and what is our price point, because it is possible today to make these HCV, sorry for the abbreviation, it is possible today to make available these treatments, particularly for hepatitis C, available at $60 for the full treatment course in Cameroon. Now, just to be precise, I know in Cameroon we use the 12 weeks, the treatments that are taken for up to 12 weeks. So just to precise that the treatments that these companies were talking about are sofosbuvir and daclazazvir. Hopefully we have them registered and available in Cameroon. If yes, then we can get them at $60. I know we have, or the group here has some form of partnership, or is in some form of discussion with the MOH in Cameroon. So this is an opportunity to tap into and get MOH to engage with them and see how we can make these available to Cameroonians. That's one. Now, secondly, as you might know, Egypt went to a robust transformation in terms of hepatitis C eradication, right? I won't get into the details, but following what they did and got very, I think they've got one of the WHO medals, if you will, in terms of the HCV elimination. Now, there was an initiative by the Ministry of Health in Egypt that promised to work with sub-Saharan African countries to provide them free HCV treatments. There's a list of African countries they said they could support with this through this initiative. Cameroon is not on that list, but we were contacted by someone who said they were working at the MOH in Cameroon and who wanted to find out if Cameroon could be added to this list. Now, we got in touch with the person responsible for this initiative in Egypt, and they were willing to actually provide the DAAs to Cameroon. But the challenge was we had to figure out how the Cameroon government would pay for the transportation costs and take care of the importation of the drugs. And so they didn't want to cover any costs. All they wanted to provide were the drugs, and then Cameroon would take care of the transportation and on appelle quoi, les douanes, la douane, quoi, que ça rentre dans le pays facilement. Right, so that's to say that these are all a couple of opportunities that we can tap into, and I'm going to stop there just to give a chance to other speakers to intervene. Thank you.
Yeah, thanks a lot, Joel. Very deep thoughts and questions there. I don't know if Marcel, any elements of answer, and also Joel, love to hear about the. If you could also share a little bit about the experience of Egypt. I think Egypt has such a wonderful success story when it comes to the hepatitis C eradication campaign. I think I was part of that meeting in 2018 in Egypt, where the Egypt Ministry of Health received this medal at the time for their work with the eradication of hepatitis C at the time. So I'd love to hear if you could share a little bit more about the Egypt experience and what you think worked for them and how you think Cameroon could use some of those success stories in our own unique context. Joel.
Yeah, briefly, what I can say is that, so how they got to the point where they had like a tremendously high burden of HCV was they had like several, maybe decades ago, I think it was a leishmaniasis treatment campaign involving injection treatments, in which people were being injected to treat leishmaniasis without, changing needles. This was several decades ago when, needles were being used on more than one healthcare, I don't want to use the word patients, but needles were used, several on different people in clinical settings, right? And so this is how they unconsciously transmitted HCV to, a good number of the population unknowingly at healthcare facilities. So they acknowledged this and then decided to eliminate HCV because it was a real problem. And if you look at the rates of HCC back then in Egypt and compared to today, you see that it has decreased significantly. So that led to higher rates of HCC in the country as well. So it was a huge expense for the government, right? And so they put in place an HCV elimination program. And one of the biggest plus that they had was that they manufactured the DAAs. So they don't import them. It was super cheap for the government to make the treatments available to people. And one thing that you need to, I guess we all know this. Most of you are clinicians. I'm not a clinician. I'm a healthcare advocate working in public health. But one thing I know about HCV is that people live with HCV for even 20 years without knowing they have HCV, right? The symptoms don't manifest, right? You can have it for 2 decades without even knowing, right? When symptoms start manifesting, it means it's getting worse. Like you're getting probably close to HCV or something like that. So that's to say that one of the first things they did was mass population screening. They screened almost more than 90% of the population was screened for HCV. So that is a good step for finding the people who are infected. And this is the reason why most people, if you look at the WHO reports on HCV, the last WHO report that was launched during the World Hepatitis Summit that took place in Lisbon, I think in April, it states that less than 25 people with HCV are diagnosed. This is because the symptoms don't manifest until the disease progresses, so maybe to fibrosis, right? So people are not diagnosed. So you need population-wide screening campaigns to identify those who have HCV. And out of those screened, this is less than 25 at the global level, only about 15% actually are treated, right? So just make the comparison and see how many people are screened and then are treated. And one of the biggest reasons why most people are lost to follow-up is because the diagnosis process, of course, as we know, is complicated. Even here in the United States, like we lose patients to follow-up. Follow-up is complicated because people need to be screened whenever the screen, if they have the screen positive, then they have to do an RNA test. Now, when you do the RNA test, if it's positive, then you probably need to do a fibrosis test. You need to be screened for HIV, for HBV to avoid reactivation of HBV when you're injected on treatment prep. There are a lot of different steps involved in the diagnosis process, and this is how people just get lost to treatment. So that was just for a background. I hope that's helpful. Thank you.
Yeah, that was very helpful. Thank you so much. Please, let's, I don't know, Dr. Marcel Nzoume, I think Joel asked some two really pertinent questions. The first on DAAs being used in Cameroon, and also the second on really how to leverage this platform to, this collaboration between the HCV elimination group in Egypt and potential collaborations with Cameroon. Dr. Marcel.
Et merci, Brian. Je vais peut-être répondre en anglais parce que je constate que, en français autant pour moi, parce que je constate que Joël s'exprime très bien en français. Voilà, je pense que l'histoire, voilà, l'Égypte et le Cameroun ont une histoire un peu similaire parce que la transmission de l'hépatite virale en Égypte et au Cameroun, c'est des transmissions qui sont des transmissions dites, je dirais, iatrogènes. C'est-à-dire qu'elle a parlé tout à l'heure de l'épidémie de la bilharziose en Égypte. Et nous savons qu'au Cameroun aussi, comme je disais tout à l'heure, entre 1920 et 1960, avec la vaccination de masse, il n'y avait pas des seringues à usage unique. Donc, il y avait des pistolets qui passaient d'un individu à un autre. Et avec des études scientifiques qui ont été faites, qui ont montré, au travers des analyses phylogénétiques, qui ont montré effectivement que pendant cette période, il y a eu une transmission du virus, donc de l'hépatite C. Donc, c'est pour cette raison qu'on voit que l'incidence de l'infection par le virus d'hépatite C dans notre contexte, c'est-à-dire que non, voilà, la prévalence était certes élevée, mais en termes d'incidence, nous avons une incidence quand même qui est relativement faible. Voilà, avec toutes les précautions aujourd'hui dans le cadre donc, de la transfusion sanguine, on constate qu'effectivement, et connaissant aussi les voies de transmission du virus d'hépatite C qui sont très différentes parce que la transmission est une transmission qui est essentiellement parentérale, contrairement donc au virus donc de l'hépatite B. Voilà. Donc, on espère que dans un avenir proche, avec l'avènement des antiviraux à action directe, direct acting antiviral, que nous allons assister donc avec le dépistage, donc au préalable du dépistage, nous allons assister donc à une diminution considérable, voire une éradication donc de l'infection par le virus de l'hépatite C. Voilà. Donc, c'est ce que j'avais à dire à ce niveau-là. Maintenant, en ce qui concerne donc les antiviraux à action directe, bien évidemment, au Cameroun, nous avons ces antiviraux à action directe. Il faut dire qu'il y a eu il y a eu des progrès qui ont été faits. Je pense qu'en 2016, le ministère de la Santé publique du Cameroun a pris le problème très au sérieux, et raison pour laquelle, donc, au niveau du ministère, il y a un comité donc, qui a été mis sur place. Et dans différentes formations sanitaires, il y avait ce qu'on appelait des comités thérapeutiques et qui permettaient donc effectivement de discuter des cas des patients et avec des intrants qu'on avait pour pouvoir aider les malades. Il faut dire que pour pouvoir soigner les malades, il faut dire que le coût de ces médicaments, c'est-à-dire que nous avons commencé pour les génotypes, je pense que nous avons commencé pour certains génotypes. Je pense qu'à l'époque, nous avions sofosbuvir plus l'Hepatologist qui étaient disponibles. Et donc, les coûts étaient relativement élevés. Mais avec le temps, progressivement, je pense qu'avec les accords de collaboration qu'il y a eu entre le ministère et certaines firmes pharmaceutiques, nous avons assisté donc à une diminution progressive. Hein. C'est-à-dire que le ministère a essayé donc de rendre accessibles ces médicaments-là, c'est-à-dire qu'à la population, bien qu'aujourd'hui, ce n'est pas tout le monde qui a donc le pouvoir d'achat afin de pouvoir donc se procurer de ces antiviraux à action directe. Alors, au Cameroun, nous avons comme nous avons de disponibles hein, comme les antiviraux à action directe, nous avons sofosbuvir plus Hepatologist qui existe en combinaison fixe. Je pense que le coût de ces médicaments tourne autour de entre 80 et 100 $, si je me trompe. Voilà, pour un traitement, ça dit que ça, c'est le coût mensuel. Et donc, pour un traitement de 12 semaines ou de 24 semaines, vous pouvez donc faire la multiplication pour avoir donc une idée bien précise. Voilà, donc, et les gastroentérologues, de plus en plus au Cameroun, nous préférons utiliser donc ces combinaisons. C'est vrai, elles ne sont pas très en sécurité parce que la combinaison sofosbuvir Hepatologist pour l'hépatite C, c'est une combinaison qui est pangénotypique. Donc, ça agit sur tous les génotypes. Et donc, par conséquent, donc, comme ça agit sur tous les génotypes, il ne faut pas oublier que l'un des freins dans la prise en charge de ces malades-là, ça reste encore des examens. Les examens médicaux, les examens de laboratoire qui sont censés réaliser. Ces examens de laboratoire coûtent excessivement cher, notamment donc la charge virale et notamment également donc le génotypage. Donc, certains gastroentérologues ont pris la culture donc, voilà, de traiter les malades avec des molécules pangénotypiques pour éviter donc, de leur faire dépenser en faisant donc un génotypage. Donc, à côté de sofosbuvir, je voudrais dire au docteur Joël tout à l'heure qu'il y a également sofosbuvir, donc c'est disponible au Cameroun à un coût qui, je pense, est relativement, ça dit que c'est moins que ça. Je pense que ça doit être autour de, voilà, autour de 50, 60 $. Cette association-là. Mais de plus en plus, nous avons abandonné l'association Sofo-Lédispasvie parce que c'est une association qui agit essentiellement sur le génotype, sur certains génotypes. Donc, ce n'est pas pangénotypique. Donc, voilà, on évite donc de l'utiliser. Voilà. Donc, c'est ce que j'avais apporté comme contribution.
Grand merci, merci beaucoup, et merci aussi à Joël. Joël, I'd like for you to connect with us or with Marcel after this. I think it would be great collaboration there to see how that Cameroon can be part of that. Maybe to initiate conversations on how Cameroon can be part of this cohesive action. Franklin Malabo.
Yes, thank you, Dr. Brian. Yeah, Franklin Maloba. Yeah. Well, thank you very much, Dr. Marcel, for this excellent presentation. Yeah, as a child or person who was working in the royal area in Cameroon, precisely Giden, the North region, and also a boy who grew up in the royal society, like Ikona in the Southwest region, I think that is a pertinent topic. And I think that these are the people who are really touched. Yeah, first of all, during your presentation, I think you mentioned about alcohol, liver cirrhosis, as a lot of Cameroonians consume alcohol. And also in your data, you show that the ages between 20 and 39 were the most affected people with hepatitis B. So in your opinion, I don't know, I did not see the statistics that were illustrated on liver cirrhosis that could be caused just by alcohol, and also that which could be caused by aflatoxin, which is from food. I think this data will be important for policymakers to really know how to go about this, because a lot of Cameroonian drinks and a lot of Cameroonian consume peanut as their main source of protein and even vegetable oil. So I think that this data will be very important to actually guide policymakers like us who grew up in royal environment. Peanut was very vital for our nutrition. Yeah, so those data will be important. Secondly, according to the National Institute of Statistics, about 10 million Cameroonians live under $1.8. That is less than 1,000 francs a day. You can see the level of poverty, that's about 1/3 of the population. And we know that in the rural areas, hospitals are not there. Blood transfusion is current because of the most malaria is highly endemic, which means that they always do transfusion. Vaccination is an issue because of cost of electricity, which means that there's poor storage of these vaccines. And also, you know about the infant mortality transmission, which is high. So in your opinion, as an expert, with all these disturbing phenomena in Cameroon, what do you think can be done to help this Royal Society? Which, you know, all of this exposure are there, especially in terms of nutrition and also drinking, because they need to drink to forget their sorrow and remember their mystery no more. So please, how can this help? How can the Royal Society in this case be helped? Finally, for those who are infected, as you mentioned, we do not have facilities. What do you think with their poverty could be the way forward to really help them? Thank you.
Thanks, Marcel.
What's the co-prevalence between, what's the level between hepatitis B and alcohol usage? Is there any study that have shown the relationship, those with hepatitis who consume alcohol, the risk of developing carcinoma or liver cirrhosis? Is there any study on that?
Yeah, Dr. Marcel shared some. Yeah, I can give it over to Dr. Marcel.
Yes. As I just said, okay, we know that, okay, thank you, Brian. Concerning alcohol consumption, so we all know that, okay, alcohol itself, chronic consumption of alcohol, excessive chronic consumption of alcohol actually lead to alcoholic liver cirrhosis, and why not later on liver cancer. So, and when there's a co-infection, I mean, when we, as I just said in my presentation, when concomitantly there is an infection by hepatitis B virus or C virus, it multiplies the progression rate of these, liver cirrhosis, and even of the progression rate of liver cancer. So this is known. I've given some figures. There's a correlation that exists. So tackling alcohol consumption also, I think I'm not very in a better place to, I mean, to give, I'm not really in a better place to give the management of people who maybe are addicted to alcohol. So, but I think that, as I said in my presentation, that we should actually raise awareness for those who do that, to have in mind that alcohol consumption can actually lead to chronic liver disease. So that's what I had to say, Brian. I don't know if someone has something to share. Yeah.
Yeah, thank you. He also mentioned the question about aflatoxin, which then in terms of how to measure the prevalence, or in terms of surveillance for that specific risk factor in Cameroon, anything you're aware of that quantifies the risk of aflatoxins in general in the Cameroon context?
And sincerely, no, in my research, I've not had a study that was actually done that shows the code. I mean, that shows that established the relation, the direct relation and the prevalence of aflatoxin in chronic liver disease or in liver cancer.
Thank you. Please, for the next set of questions, please just make your question brief. Ideally, if it's just one, that'll be great. Jude and
I think you didn't give a guide on for royal areas who are already faced with this. What could be their way forward? Should they be just left there, or what could be the way forward for him? What does he think?
Yeah, well, thanks, Maloba. We'll try to integrate that question in as we move on with the discussions. I understand the importance of rural communities where these kinds of diagnostic tests are not necessarily available, and the need to prioritize those groups as well.
Brian, so, let me add something just a little bit. And that's why Nzoume made mention that Cameroon, we lack studies. So one of the reasons why we're here today is that we should be able to carry research and not just import data, so that we can carry research locally and know what is happening. And I know during my time in Cameroon, when I was doing Mengang biology, we realized that certain areas in the West region, so when we talk about aflatoxins, there are several aspergillosis that do produce, when you see granite, peanuts, and you find the fungi in them, a lot of them produce very toxic fungi, and these are all about methods of storage. And most people don't know about this. So there is need for our toxicologists, there is need for more research, because we found there were areas back in several regions where the incidence of hepatocellular carcinoma is more than average. And also the prevalence of hepatitis B and C and alcoholism is low. So that actually gives you kind of a correlation, not generally a cause and effects thing. So more research needs to be done, and the government needs to get itself engaged. There is now vaccination that is available even in rural areas. It's free. Hepatitis vaccine is given to everyone. But I think we need more advocacy, more government engagement in order to save the rural community. I just shared the flyer from the Ministry of Health showing you what the prices are. As Marcel said, these were the ones that are the subvention coming from the ministry. I think I got this some few years back, and I thought it was still in my mailbox. And it shows you that there is some effort, but we need more effort. We need more people who have connections to be able to engage some of these pharmaceutical companies. And we need Cameroon to embrace this. So we need advocacy at multiple levels. So that's just what I wanted to add. And most of Maloba's questions were more of things that have to be done. They were pertinent questions, but most of those things we here in the town hall, the people of Cameroon, we need to engage to get more data. We need to also engage in order to see how we can do to treat and not forget the rural community. So that's my input.
Okay, thanks. Let's just take a brief question from Jude and then move on. Just make your question. Thanks.
Yeah. Hello, everyone. I'm Jude. Thank you, Dr. Marcel, for the presentation. So for me, my question is still in line with still regard to this distribution of this disease. If I look at your data, which you presented, I think in the North region, it's just a comment, it's not really a question, but I think probably, as the others already said, there could also be other factors which could cause this. Like, in the North there, these people are really kind of pastoral nomads. They rear a lot of cows and all the like. I don't know if, of course, there is limited research and data, but there could be an association between this fasciolosis. I don't know if it's already in literature with liver carcinoma. So probably there could be an association, because the data you showed there, though it's quite old from 2014, but there were high rates in the northern part of Cameroon. So probably that could be a factor. And then one question I just want to ask is, like, since you're practicing in Cameroon, do you think that the current measures or public health interventions which the government is having in place, do you think they are actually helpful in controlling this infection, like, to your opinion? Or do you think that they are not helpful, and maybe new approaches should be brought regarding the recent prevalences? Or, like, what do you really think? Or if you're in a place to advise the government on what to do to reduce this infection, like, what will you suggest? Thank you. Those are my questions.
Okay, thanks. Marcel, any brief response?
I would just say brief response here. So I think I'm not in a better position to say, okay, I just said in my presentation to judge or to make comments about the government, the government policy here in Cameroon concerning the prevention and also the control and the management of this topic. So what I can say that in terms of public health intervention, as I just said in my presentation, and Mono also said it. So I think a lot of things has been done. A lot of things are still to be done. And all what I can say that we believe that as we are raising our awareness, that at the level of the operational level, at the operational level of the Ministry of Public Health, they'll be able to reinforce. And I think that the ministry, and with this with the direction de la lutte contre la maladie, they are doing the best in order to come up with a good policy or in the management and the prevention of these of viral hepatitis and those liver cancer.
Thanks a lot, Marcel. I just want to take, yes.
Yeah, Brian. So anything that causes cirrhosis to the liver, it could be fasciola hepatica, it could be schistosoma mansoni, japonicum, it could be schistosoma intercalictum, any of them that actually causes cirrhosis increases the risk of HCC. So we should just know that anything that leads to cirrhosis in the background causes increase in risk of cirrhosis. So I just wanted to add that. And in the north, there is scarification, very common. And the use of blades, we should know that. And that increases transmission of both hepatitis B and C. And areas where you do have scarification, don't forget all those things. Those are very common risk factors. So those things really do correlate. Those were things, I'm saying all of this because I worked in Cameroon and I did a lot of research during the time with Biologists when I was there. So those are things, those are risk factors, underlying risk factors. And the north also consumes a lot of peanuts and they grow a lot of peanuts. There are a lot of aflatoxins there that have not been studied. It's opportunity for us to study our country, to do research. This is a big research question in Cameroon. HCC is the most common cancer between male and females. We have to research it. If we took prostate cancer away and we take breast cancer out, HCC becomes the burden of the disease in Cameroon and in Africa overall. So it needs research. And I think we cannot really create data where there is no data. So it's a call for, Marcel is calling, it's a call for us to engage and engage our medical students, our universities up north, and everyone to try to figure out what is going on.
Thank you. Thank you. Again, I want to take a moment to acknowledge the presence of the Dean of the Faculty of Health Sciences of the University of Boya, Professor Gregory Hale Ekane. It's really great to have you among us, Prof, and please, you have the floor. Prof, if you're speaking, you're muted. Okay. Okay, I think we're going to come back to Professor Gregory afterwards. Ghislaine Fodio.
Okay, thank you, Bram, for giving the floor. Okay, I'm Dr. Stanfujo. I'm working in the hospital. I'm a radiologist. So I just want to thank Dr. Marcel for the presentation. And just to throw more light on what you talk about, what radiologists are doing in General Hospital Yaoundé. Because I took part of the first session, so they're working with the team from France. And they were doing some kind of trans-arterial chemoembolization for HCC. One is early. There are some criteria. We know list them there, but we know that early diagnosis, radiology. But the point that most of our patients present late. But we can try. So some of the clinicians that have some case that see early, they can try and send the radiologists there can study and see why they're waiting for the team, or they can do something on their side. But back to bingo, what we do at time, our surgeons, some used to do some liver resection when the lesion is localized on wax segment without metastasis. But in the practice, Dr. Marcel was talking about the challenges of radiologists and clinicians. I would like to ask you a practical question. Because in radiology, we used to talk about the diagnosis of HCC with the triple CT scan with the enhancing liver lesion. So on its practice, for those that have, because those that have a single lesion, and you know that biopsy at times is challenging. Some surgeons are afraid that it's vascularized. So most of them rely on imaging. And at times, if the protocol is not well done, may not have a clear diagnosis. So I don't know, on his own practice, how does he trust what the images the radiologists give him when he cannot have biopsy to confirm? Give you also that alpha protein can also throw more light on some patients. How does he do his daily practice to really be sure HCC on a single lesion? Thank you.
Marcel?
Thank you very much, Dr. Fejo. I would just like to share the experience here in where I work at the Bafoussam Regional Hospital Center. So where we have a radiologist, we have Dr. Mulio, so who is a radiologist. So in these situations when we have single lesions, and then we don't have any, and the imaging is not very characteristic, we cannot actually define. If we cannot go for MRI, we go for biopsies. We actually do biopsies, liver biopsy. So where with Dr. Mulium at the Bafoussam Regional Hospital in such cases. Thank you.
Okay, thanks for that, Dr. Marcel.
Brian,
yeah.
It's very important. This is why it's super important that we build our interventional radiology team in Cameroon. I think that's a big problem. So we have good radiologists, but we need to build interventional radiologists. It's so important that diagnosing HCC through biopsy is not supposed to be a very risky procedure if you have an open window. So you need the right training. This training goes back. If you don't meet the LIRACS criteria 5, you are not sure. So, and right now, the future in HCC management is that we are going to be needing biopsies. Why? Because new studies are showing that we have mixed tumors, HCC/cholangiocarcinoma, and we need next generation sequencing to treat some of these patients when they progress. So back in the days, it was just radiological criteria because it was more of a radiological disease to treat by interventional radiologists and surgeons. But things are changing. So I think it's a call for Cameroon to train interventional radiologists, not just depend on the team that leaves France and comes. They should come from France. We should train them and train more of them so that every region has an interventional radiologist who is able to get us tissue. As I will always tell you in oncology, no tissue, no issue.
Okay, thanks. Totally agree on that. Guy Roger Njapa. If you're speaking, we can't hear you.
Hello.
Yes.
Yeah. Good evening, everybody. I am Guy Roger Senga Japa. I'm gastroenterologist in Bafoussam. I am Marcel's colleague. I would first of all like to appreciate his brilliant presentation, which actually permits us to have an idea of the burden of hepatocellular carcinoma in Cameroon and the main challenges in diagnosis, management, and establishing prognosis. So I really give a round of applause to him for the brilliant. I just want to make a contribution from where he landed. Prevention is better than cure. It is clearly established that hepatitis B and C are the main causes of hepatocellular carcinoma in our setting. But it is more of a problem with the B virus than the C for now, which unfortunately affects mainly the younger people. Studies have been done which show that transmission mainly occurs either during delivery from infected mothers or early childhood period. And luckily, in 2005, I would say so, the Ministry of Public Health decided to introduce the vaccine against hepatitis B in the EPI, Expanded Immunization Program. One of the main challenges that we are going to face, actually is that if you meet the WHO 2030 objective, that is to reduce by 90% the number of new infections and by 65% the number of premature deaths related to hepatocellular carcinoma. Prevention, we have to be emphasized more on prevention. And talking about hepatitis B, we have to actually go a long way to be certain that children or infants who have been vaccinated against hepatitis B actually are protected. There is growing evidence which show that many of these infants who got vaccinated at birth, that is the vaccination program which begins as from the 6th week, are not forcefully protected. And clinicians and let me just say healthcare provider at large, you have to actually have an open eye on that issue to make serological control, post-immunization serological control a habit before these children go to school. Also, you have to do well to make sure that pregnant women are screened. It's a study we conducted somewhere around the South. We showed that about 45% of pregnant women coming to deliver never knew their hepatitis B status. And when they are screened and they are negative, policy have to be put in place, established to make sure that they are vaccinated. I think that shall be the main way to reduce significantly the overall prevalence of hepatitis B in our setting, but also reduce mother-to-child transmission, because can you imagine a pregnant woman who on pregnancy X comes negative, finally comes 2 or the following year or 2 with an infection or hepatitis B infection. So these are the 2 main issues I think which are cornerstones for the prevention of hepatitis B and then the prevention of hepatocellular carcinoma in our setting. Make sure that we have immunized, not only vaccinated, but immunized children, and make use of antenatal clinics to screen and protect pregnant women. This is what I actually wanted to add to the presentation that Dr. Nzoume presently did. Thank you very much.
Yeah, thanks a lot, Dr. Njapa, and really congratulations for your great work and also really excellent contributions. I don't know if Professor Gregory Halley is able to unmute himself now. Prof. I know Professor Halley had some issues with unmuting himself earlier, so I don't know if you've been able to fix the audio. Okay, while waiting for, let me see if we can try to unmute him from here. Still not able. Try to check the what mic your computer or your phone is using. Maybe that might be the issue. Okay. All right, please. I would like to hear from Dr. Ndita Ivor, always a gastroenterologist here in the US. It would be interesting to hear your perspectives as well. Love to hear your experience in terms of what you see as a standard of practice in the United States when it comes to the management, the scale of the problem of hepatocellular carcinoma here in the US as well. Dr. Ndita.
Hey guys, good afternoon, man. I want to start by really apologizing for missing this very important talk that I wanted to be part of it from the outset to the end. Because hepatitis B and HCC is like a baby for me. And for me to have missed this presentation, I'm so disappointed. But I want to congratulate the speaker of today. From what I hear, it sounds like it was an excellent presentation. Some remarks I may make here may end up, I hope I'm not repeating what others have said. But one thing that I really wanted to point out about Hep B, I don't know if they've talked about this, but is the uniqueness of hepatitis B compared to the other. I heard somebody talking about Hep C, where Hep C cannot really cause you hepatitis, cannot cause you HCC, but for sure, you need to go through the stage of cirrhosis before you can have HCC. But the main difference with HBV is the fact that it's a DNA virus that simply inserts itself into your DNA and can dictate how your DNA conducts itself. So it is very important that I am hoping that the audience is aware that if I have Hep B and Hep C, they are not treated the same. Because Hep B, even without developing cirrhosis, puts you at risk of liver cancer. It's the reason why in the United States, for example, every immigrant from a poor resource country is certainly at risk. And it's why for African Americans, immigrants, we start screening for HCC at the age of 20. You can, if you, in contrast, if you are a Caucasian, you are an American born here, and you happen to contract Hep B, we will start screening at the age of 40 for men. And for women, we even go up to the age of 50. So it speaks as to the uniqueness of Hep B that we cannot sit and wait for you to have cirrhosis before we start screening. And I heard somebody comment about public health importance. Certainly in Cameroon, we do have the possibility of doing ultrasound. Even in the US, we simply do an ultrasound and we do plus or minus an alpha fetoprotein. But the ultrasound is the central focus. And we do it every 6 months. So critical. Let these people, I cannot count the number of Cameroonians in where I am in Minnesota that have died from HCC simply because nobody paid attention or did screen these folks for Hep B and manage them. Each time I give a talk to an African American community, one of the things I say, make sure you ask your primary care physician to do is that you must be screened for Hep B. That's because our practices back home, our habits back home, primarily put us at the higher risk. I remember Hep B is endemic in our country, for example, Cameroon and most other African countries. It's not the case in the US. Hep B is actually an exceptional disease among Caucasians. So something that I would simply say everyone, not only pregnant women, if I were a public health advisor in Cameroon, I would advise that everybody should get screened. It's a quick test. It's not that expensive. And if you're negative, get vaccinated. But what I really wanted to point out, I also know that Dr. Muno mentioned things about schistosomiasis and all those causing cirrhosis. In technical terms, it really doesn't cause cirrhosis. They do cause portal hypertension. And of course, the number one cause of portal hypertension worldwide is actually schistosomiasis, not liver cirrhosis. Schistosomiasis rarely, if ever, goes to liver cirrhosis. So while all other causes of liver cirrhosis, we can cite them: alcohol, chronic viral hepatitis, autoimmune liver disease, metabolic liver diseases like Wilson, hemochromatosis, alpha-1 antitrypsin deficiency, the cardiac cirrhosis, and these things must go through the stage of cirrhosis before you are at risk of liver cancer. Otherwise, you do not have a risk of liver cancer. Of course, I did not cite what we call today liver, fatty liver, or commonly known as metabolic dysfunction-associated steatotic liver disease, which is becoming the leading cause of liver cirrhosis. So critical for our providers to remember that and get tested. Not only for that, even those that had prior exposure and recovered, make sure these are patients that we pay attention because they are at risk of reactivation, especially in circumstances where they're getting any immunosuppressive medication. I think I will leave it at that. I don't want to monopolize the talk here this afternoon, but I'm beating myself in the head how I did not show up at the beginning of this presentation and only joined now. But I hope hopefully, those things I'm talking about, somebody touched on them. But I will be in the background here. If anybody has any question that they would like to ask that I can be helpful in addressing, I will do that. So thank you very much.
That was really great. Thanks so much, Dr. Dita Ivor. He's always a fervent participant of the town hall and has been a presenter here several times, and I can understand how this topic is really close to his heart. And thanks so much, Brian. Should I bring in Taze, Sydney?
Yes.
Okay.
Hey, hi Elvis, hi Brian, and thank you, Dr. Marcel, for that wonderful talk. Yeah, I would like to make a few comments and a few contributions regarding some things that Dr. Dita mentioned, some things that Dr. Ghislaine mentioned, and also make a few comments on what Dr. Muno said. Obviously, whenever you talk to somebody, any patient about liver cancer or any kind of cancer, the first thing they ask is, how can I get treated? Dr. Dita talked a lot about the screening to identify people who are at high risk. And Cameroon, as a take home, we have a very good ultrasound expertise in Cameroon. And there's an advanced form of ultrasound called a fibroscan, which is available in Yaoundé right now. And what that does is it can actually score the extent of your liver disease, because like Dr. Dita said, screening is how we are going to get ahead of this problem. We can identify those patients that have a high risk, and then we can now follow them using these fibroscans. So that's something that you probably want to ask when you go and see your doctor. You want to ask them if you can get that. It's actually an inexpensive technology, and because we are already good in ultrasound, going from ultrasound to fibroscan is a natural. It's going to be very natural for the centers that have good ultrasonographers and good radiologists. And then the next point is I'm going to talk about tools that we already have in Cameroon that we can use today. Dr. Ghislaine mentioned the chemoembolization that was done. I think that happened sometime around February last year at the University of Yaoundé. Some good pioneering work that was done by I think some guys from France. And the importance of the IR doctors cannot be underestimated, or we have to really emphasize, because once you are able to do chemoembolization, then you can use that same skill set, the same set of experts, to now move from chemoembolization to radioembolization, which Dr. Muno talked about, where we're injecting these very, very tiny radioactive sources into the tumor, and we can go in there and ablate the tumor, and that can achieve some local control, or even in the worst case scenario, it can actually achieve a lot of symptom relief. So there are some things that can be done that we should think about to actually make a difference. Because when somebody comes to me, or they're talking to any of the doctors, they want to know, how can this actually help me tomorrow? So let's encourage them to get screened, and then also there are current options right now in Yaoundé for treatment of some of these HCC cases. And then the last point I was going to make is obviously the treatment options that are available for total control, okay, for HCC is of course transplants, which obviously it's expensive, but of course SBRT, which is not available in Cameroon, but last but not the least is something they call RF ablation. We have to try to use tools that we can do in Cameroon, right? Transplants are expensive, SBRT is expensive, but RF ablation is not. It's not an expensive technology. So those are three things that if we put in our resources, put in our money, we can actually do today. We can do in a very short time. So I really want to encourage us to try to look at some of these practical tools that can make a difference tomorrow in the lives of our people in Cameroon. So yeah, so those are the 3 points I just wanted to comment on.
Can I make some remarks here, if you don't mind?
No, sure. Go ahead, Dr. Dita.
So he is right that the strategies to manage HCC are somehow limited in Cameroon. Of course, he talked. Our goal first is prevention, but let's say you then develop the lesion. What do? Several factors come into play. But if you were to ask me in Cameroon, if somebody develops a single lesion, what would be the best approach to manage? If this lesion is surgically resectable, that is the optimal option in Cameroon. Or because I'm saying this because when I listen to Muno, it sounds like we do not have the ability to do to use interventional radiology to do the local regional therapies that we do, including the transarterial radioembolization and transarterial chemoembolization, the tear and the pace. Whether we're using alcohol or we are using radioactive substances or other chemical agents to destroy the lesion. Those are all things that we will do here. And he talks about liver transplant. Even liver transplant in these patients is unique because, as you know, we have the Milan criteria that we need to use to judge who goes for transplant and not. But most importantly, even when you are outside of transplant criteria with the lesion, for example, more than 5 centimeters, we can downgrade that lesion with a local regional therapy to make you eligible for transplant. So transplant is the best. But in a setting like Cameroon, where we cannot do these local regional therapies, and where it sounds like the only best option is surgery. If the patient is functionally good, a good MELD score, a good child puke score, surgery for a single lesion or even 2 lesions that can be surgically resected will be very important. Now, I think before we even go to, we talked about the screening. And he talked about the fibroscan, or what we were described today as non-invasive test evaluation for fibrosis. The fibroscan is helpful, especially in making a decision whether this is a patient we should treat or not. Because to treat, as you all know, most patients with hepatitis B will never have any problem from hepatitis B. But of course, it doesn't mean we will not pay attention to them. So we do not treat every person. And we have criteria that we use. One of those things we do is whether is the patient having any chronic liver damage from the hepatitis B. And that will be assessed non-invasively with a fibroscan, because we don't want to be doing liver biopsies on people all over the place. And the next criteria we'll use will be your liver enzymes. How high are they? How high are they? And the last one is the viral count. So these are the 3 main things that we will use to make a decision whether you should be treated or not. Now, I am not saying that treating is curative, not at all. And the evidence whether it prevents the development of HCC is very controversial, but for sure it does slow the damage that the virus can cause to people in which it is an active disease. So fibroscan is not primarily used for screening, but rather to determine if you're developing any fibrosis. And usually patients that have stage 2 fibrosis or more, we will put them on treatment. I know in Cameroon they have lamivudine. I don't know if they have tenofovir at this point or not, but I know primarily they use lamivudine. As we speak, I think I'm actually dealing with one Cameroonian who is actually out of the country now trying to get treated for a lesion that is from nowhere, a lesion of about 9 centimeters. And these, I mean, I don't want to give any information that releases the person's identity, but this is a real problem. And this person had an ultrasound done in the last 12 months. But suddenly now he pops out and has a lesion of about 9 centimeters. What was the quality of this ultrasound that was done about 12 months ago? Very difficult. So I'll leave it at that again for now. Thank you.
Yeah, absolutely.
Yeah, thanks a lot, Sydney, and also thanks a lot, Prof. Sandita. Docteur Marcel, je ne sais pas si tu as un élément je ne sais pas si tu as un commentaire par rapport à certains points qui ont été élevés par Tazé.
Okay, yeah, thank you very much. I just want to say, okay, the problem you just said, talk about the fibroscan, the evaluation of liver fibrosis. So yet again, I want to say, yeah, the cost is being done, yes, in Yaoundé. It's been done also in Douala and also in Bafoussam. But the cost. how many Cameroonians are able to afford it? So we still come back. Prevention is better than cure. So, but what I want to say is that, okay, 80%. I did a presentation. In my presentation, I said there was we had 80% of HCC had been diagnosed at an advanced stage. That means if we take together advanced stage, no, then therefore not curable. They cannot benefit from any curative therapy. So we should take in consideration that. So that's why I was trying to say, okay, as my colleague said, prevention, as Dr. Dida said, okay, prevention. So we should focus on prevention. And because most of those therapies actually, we do know all those things, but actually they are not, in terms of accessibility, we find difficulties in helping our patients. So I just wanted to lay emphasis that 80% of our patients, as I just, for the study that we presented, are being diagnosed in an advanced stage, Barcelona B, C, and D, and mostly C. Thank you.
Dr. Nzoume, do you find any utility in the use of fibroscans? And you said they're available in 2 regions in Cameroon. Do you find any utility in terms of screening for fibrosis and just as Dr. Taze mentioned and also Dr. Nzita?
Tout à fait, c'est-à-dire que l'évaluation de la fibrose hépatique est quelque chose de fondamental dans la prise en charge donc des patients qui souffrent donc qui ont une infection chronique à l'hépatite virale, que ce soit l'hépatite virale B ou l'hépatite virale C. Et aujourd'hui, avec la prévalence, c'est-à-dire que de la maladie de la NAFLD, non-alcoolique fatty liver disease aussi, c'est aussi important donc de pouvoir évaluer donc la fibrose hépatique donc, chez ces patients. Donc, l'évaluation de la fibrose hépatique est indiscutable. Mais le véritable problème qui se pose en ce qui concerne cette évaluation, c'est d'abord l'accessibilité. C'est-à-dire qu'en ce qui concerne le fibroscan, il faut le dire. C'est vrai qu'il y a d'autres méthodes aujourd'hui qui sont des méthodes non invasives qui permettent donc d'avoir avec des paramètres, certains paramètres, à savoir le taux des plaquettes, les enzymes du foie, qui permettent donc d'avoir une idée indirecte sur le degré de fibrose hépatique. C'est le cas, donc, effectivement, des tests qu'on appelle KIT4 ou APRI, que nous pouvons, de temps en temps, que nous utilisons, voilà, pour l'évaluation de la fibrose hépatique. Mais comme le docteur Nita l'a dit, voilà, en ce qui concerne donc l'activité virale, cette activité virale tient en compte, n'est-ce pas, la charge virale, les mouvements des enzymes au niveau du foie, et puis donc l'évaluation de la fibrose qui permet donc d'avoir tous les critères permettant de mettre les patients sous traitement. Je voudrais également, comme commentaire, ajouter et rassurer donc le docteur Dita à vous dire qu'au Cameroun, nous n'avons pas seulement la lamivudine, mais nous avons également donc le tenofovir dans la prise en charge donc des patients qui sont éligibles au traitement pour l'hépatite virale B. Nous avons aussi de l'antécavir, l'antécavir, et de moins en moins, nous avons cet effet de tachyphylaxie avec et de résistance avec la lamivudine. Raison pour laquelle nous utilisons très peu au Cameroun aujourd'hui la lamivudine dans la prise en charge de nos patients qui ont une hépatite, une infection au virus de l'hépatite virale B. Donc, nous utilisons plus donc, le tenofovir et au besoin, effectivement, donc, nous pensons qu'avec l'avènement de l'antécavir, nous pouvons donc aussi l'utiliser, mais en sachant que les patients qui ont été préalablement exposés à la lamivudine peuvent faire donc des résistances croisées avec l'antécavir. Merci.
Merci. Merci beaucoup. I just want to really appreciate and say we are really deeply honored to have Professor Gregory Hale-Kane, who is the Dean of the School of Medicine of the University of Buea. And he's been the leader of the institution for quite some time now, held medical education at the University of Buea. So we are really thrilled and deeply, deeply honored to have you among us. And Professor Gregory, please, you have the floor. Welcome to the town hall, and please, you have the floor.
Yes, thank you, sir. I don't know whether to call it a village hall, a town hall, or an academic hall. But all the appellations, they seem appropriate. Because listening to you guys talk, I think it's one of the best evenings I've ever had. And if there is, I don't know how many students are taking part in this teleconference, this Zoom conference. But my greatest wish is that it should be extended to students, because even at the level of the university, one of the wishes is to show that this inter-university collaboration is possible. And with the advent of, not the advent, with the exploitation of e-learning now, it cannot be, and there cannot be any opportunity that is better than this, because I find myself more in a classroom than assisting in a Zoom conference. If there is one take-home message I want to go with, is this multidisciplinary approach in treating cancer. I think the resources here are too limited for us to be comfortable. But if we find ourselves in a zone where we have limited resources, one of the strategies we can adopt is this inter-multidisciplinary collaboration. It's a big problem. I think we have a tendency that even with the few capacities that we have, we sit on patients. We sit on patients for one reason or the other. We want to sacrifice the comfort of patients for other ends. I think if there is something I remember here, when I hear intellectuals talking, we hear seasoned clinicians talking, it can only be a good way of sending this message through. That singly will not succeed, especially with the limited resources which we have, but as a group, we'll go better and improve on our health system, especially in the domain of oncology. Thank you very much.
Yeah, thank you, Professor Greg, and thanks a lot for your leadership and for your work with the University of Buea. I just want to give the chair of the town hall to give a few words, so maybe to share a few words. Dr. Mona, please.
Wow. So I would love to start by thanking everyone who participated here today, not forgetting Professor Hale for joining us. And we've been going on for the past almost 4 years, and we have encouraged all medical students, nursing students, scientists, everyone to join the town hall. So the town hall is an open platform where we discuss healthcare problems, and we are at the 102nd episode. We do that every fortnight, and we have invitees who come in and try to initiate a topic that we can discuss and also reflect on, as we're doing here today. So you are welcome to participate as also a presenter and encourage others, and also all the students in Buea and every other university, they are welcome here. We've had the Minister of Public Health here twice. So today I would really love to thank Dr. Nzoume Marcel for your wonderful presentation, and also for really emphasizing that hepatitis B, as Dr. Ivor said before he came in a bit late, that was what you emphasized, is the main cause of hepatocellular carcinoma in Cameroon. And it's one of those infections where we have a vaccine. And the fact that we have a vaccine, as your other colleagues said in Bafoussam, do we ensure that these patients are actually immunized after getting, the immunization is effective. So those are all things. Those who are not having the privilege to be within the group where immunization is free, are we testing them? Are we vaccinating them? Are we screening them? I think that has been the general message that has gone through the town hall. Prevention is better than cure. I'm an oncologist and a hematologist and an internist. I don't want to be treating these patients. There is a lot happening in the oncology world in terms of hepatitis. There are patients with late stages that we can tell you we are actually curing them with immunotherapy, but they are just about 10%. But without going to talk about that, prevention is cure, is better. Hepatitis B, followed by hepatitis C, alcohol, as we said, all causes of cirrhosis. Now we have non-alcoholic fatty liver disease, aflatoxins, which are down the list, genetic causes, diabetes, smoking, environmental causes. These are all things we should look at. But if we have an elephant in the room, which is hepatitis B, we should be able to address that. And I'm happy the discussions went towards that direction. And as Dr. Hale said, in the management of hepatitis, of HCC, there is no cancer like HCC that can lead to collaboration between all the different medical fields. We are not there yet. If Cameroon really wants to get to the point of treating HCC, we need a lot of development. So prevention should be where we should gear our efforts to. We need our radiation oncology team to be up to date and be able to do SBRT in all the regions in Cameroon. We need our hepatologists to be able to, if these patients can be transplanted, help take care of them, manage them, and treat the underlying diseases. We need our surgeons to be able to do proper resection. Even resection of the liver is not easy. So are the surgeons actually trained? How many of them have the capacity to safely resect a liver lesion and these patients stay alive? How many of transplant surgeons do we have in Cameroon? I don't have those answers. How many interventional radiologists are able in Cameroon to do transarterial chemoembolization? How many of them are able to do transarterial radioembolization? How many of them are able to do cryoablation or even any form of medical ablation? So these are all things that we need to start thinking about. Not proliferating medical schools, but making the medical schools we have now being able to train the right people we need in all specialties, using the diaspora to collaborate, not just to come in and show anything, but we should be able to collaborate with those back home, and those back home should be able to accept and collaborate with knowledge. As I said, the team from France comes in and does some kind of intervention in Yaoundé, which is good, and I hope they do train the people. So that is my last words, Brian, today. I just want to thank Nzoume for everything he did, and I just want to say prevention, prevention, and prevention.
Yeah, thanks a lot, Mono. It's always really great to hear about your expertise, and thanks a lot for all your work with the Cameroon Town Hall and your leadership all along. And again, thanks a lot, Prof, for joining us. We would love to have more and more students from the university, from the Faculty of Health Sciences, University of Boya, be engaged in these very important discussions. And there are multiple thesis projects that have resulted from discussions that have been that have started in this town hall. Research questions and research priorities, research questions, research priorities in Cameroon. So looking forward to engaging more and more of the student body back at the Faculty of Health Sciences, and also a lot of diverse expertise in different domains within the town hall that have the willingness to help and to support any educational efforts that are needed within the university as well. So thanks a lot. I just want to give the floor to Dr. Marcel for maybe your closing remarks. But Dr. Marcel, I really want to hear from you about what you perceive as the key priorities that you think the Ministry of Health should consider when it comes to this the scale of this problem of liver cancer in Cameroon. What your takeaway messages, or what are some key things you think should be priorities moving forward as we engage in this fight? Dr. Marcel.
As the key priorities, as I would say, is first of all to reinforce the public health interventions, and as it was stated, the first risk factor remains hepatitis B infection, and as we said in the presentation, as my colleagues and Mono also said, we have to reinforce the mother-to-child, prevent the mother-to-child transmission of this infection or perinatal infection by a systematic screening of pregnant women for hepatitis B. So all over the country. So, and the tests should be made available, because we didn't talk about the quality of the tests that are being used for the diagnosis of this of hepatitis B in our context. So there again, we think that there should be an homologation of these tests to come up with the test that has a high rate of, in terms of specificity and sensitivity, which is very high because most of the time also we have Dr. Mono, who was a médecin biologist. We all know that the problem that we have some cases of false negative with those tests. So systematic screening, not only pregnant women, but all the entire population, and those who are being negative, they should go for vaccination. And also for pregnant women, those who are positive, we should implement the protocol for mother to child, the protocol as far as the mother to child prevention is being concerned. So, and above that, for those who are being infected, actually they should be well managed. And saying that they should be well managed simply means that, okay, that cultural belief that we have in Cameroon, because that's a major barrier. And people believe that hepatitis cannot be treated, cannot be managed with conventional medicine. And most of our patients, I would say 98% of them, before coming to conventional medicine, they do pass through native doctors or traditional practitioners or herbalists before coming to us. And most of the time it's late. It's been late because complications are already there. So as I said in my presentation, we need a collaboration. We need a community engagement in terms of awareness. People should be, we should inform people concerning that issue and concerning that problem, and it should be addressed. So that's what I have to say, and and end up by saying that, okay, prevention again is better than cure. That's why I didn't lay any emphasis on the management or the treatment of liver cancer in our context, because we have a lot of problems. As I said, 80% of them are being diagnosed in an advanced stage, so where they cannot actually benefit of any curative therapy. Thank you very much.
Thanks a lot. Merci beaucoup, Dr. Nzoume. I want to pass it on to my fellow co-moderator, Elvis, for maybe a quick summary and then last words. Dr. Elvis.
Thank you very much, Brian, and thank you, our chair, for your leadership and for always bringing us one of the finest presenters that we have, and it was really a great topic. Our presenter was Dr. Marcel Nzoume, and the topic was liver cancer and a call to action. We've heard from him that liver cancer is the sixth most prevalent cancer worldwide, and the third cause of cancer-related mortality in Africa, and in Cameroon is the sixth in terms of incidence, cancer incidence, and the fourth cause of cancer deaths in Cameroon. He just mentioned some risk factors, and he said hepatitis B and hepatitis C were one of the major risk factors, including non-alcoholic fatty liver disease. And he said now hepatitis B kills more than HIV and tuberculosis. That was really strange for me to hear. And that worldwide, we have about 290 million people who are infected or chronically infected with hepatitis, which is really a very serious issue. And that the prevalence of hepatitis B in Cameroon is 11.2%. But that the problem of hepatitis is also compounded by co-infection with Delta virus, which is about 17% prevalence in Cameroon. These were some important statistics that Dr. Marcel provided. He also said hepatitis C has a percentage prevalence of 4%, and there is also a prevalence of a blood donor hepatitis among blood donors, which stands at 10.5%. That's really high, and that most people with this virus are less than 40 years. Less than 40 years, a very young population. He mentioned that contamination with hepatitis viral infection happens mostly from early age. That's why he emphasized the need for a screening. And he said that the surface antigen prevalence in Cameroon for hepatitis B virus is 13.4% in pregnancy. In pregnancy, that's why he insisted that there should be really high screening of pregnant women for hepatitis B. He also mentioned that 40% of pregnant women give birth without help of a healthcare professional. So this is actually compounding the problem of early transmission of hepatitis. Dr. Marcel mentioned that 48% of cases of hepatocellular carcinoma in Cameroon, in a study he cited, were among people with hepatitis B viral infection, and that most of these people are diagnosed in an advanced stage of liver disease. He also did not undermine the increasing occurrences of non-alcoholic fatty liver disease that is also leading to cirrhosis and, of course, complicates the problem of liver cancer. He went ahead to talk about some of the challenges of liver cancer diagnosis in Cameroon, among which one was the fact that there is high cost for diagnosis. And he mentioned, of course, if you think about a country where 33% of people live on less than $1, then access to diagnostic is really a limitation. He mentioned a limited availability of the diagnostic tool itself, and of course, shortage of a specialist with just about 60 hepatologists for a population of 30 million people. He talked about limited awareness of screening opportunities leading to missed opportunities to actually have early detection. Limited availability of tumor markers were some of the limitations, as well as treatment limitation relating to high cost of treatment and even the availability of treatment itself. Citing some of the public health intervention that the Ministry of Public Health could pay attention to, he mentioned the fact that since hepatitis B and C prevalence is high, then there should be some commitment for population-based screening programs. He also said we should pay attention to the association with aflatoxin exposure in terms of agriculture, materials that are used for agriculture. He said this should not be undermined, and I think Muno actually called for the need for much research to be done to be able to see the correlation between this toxin as well as liver cancer. He emphasized the aspect of alcohol consumption and said the government should pay attention to this and see what they can do to create awareness for those who are excessively consuming alcohol to know the relationship between alcohol consumption and liver cancer. He also mentioned the socioeconomic disparity and said these are some of the things that compound the problem of liver cancer. And looking at some of the preventive strategies, as we have all agreed that prevention is better than cure, he mentioned vaccination for hepatitis B, which is something the government is already doing and should do more, but that vaccination is not enough. We should be able to control for those who are actually immunized. Promotion of safe food practices is one of the things he mentioned, enhancing alcohol awareness and support services, as well as accessibility to screening and early detection program. And talking about treatment, he mentioned that we should ensure availability of surgical and radiology intervention, strengthen our oncology and palliative care, and also build capacity of healthcare workers. And above all, we've heard over and over, he said, lack of public health awareness contributes to the problem of liver cancer and really make us to miss the opportunity for early detection. Thank you very much, ladies and gentlemen. These are the few things I gathered for those who joined the town hall late. It was an excellent presentation. We meet every fortnight, and hopefully we will be meeting with you here in 2 weeks' time here for another exciting topic of the town hall. I wish you a very nice weekend.